Welcome to Course 3. In this course, we will address the clinical presentations in pathophysiology, diagnosis and tests, self-management, and clinical management for select post-COVID conditions as listed on the next slide. In Module 1, we will begin by reviewing the clinical presentation and pathophysiology of these post-COVID conditions. If you have not already taken it, there is an introduction module which serves as the foundation for the subsequent quarterly courses. This introductory module presents definitions, an overview of clinical manifestations, and risk factors for developing post-COVID conditions. You can find it on the Canvas homepage under the header Introduction. In this module, we will be covering the pathophysiology of 4 post-COVID conditions: POTS, postural orthostatic tachycardia syndrome, vestibular syndromes and symptoms, PEM or Postexertional Malaise, and brain fog. The first post-COVID condition we will review is POTS. So what exactly is POTS? In short, it is a type of orthostatic intolerance, which means that there are a constellation of symptoms that develop upon standing. The defining symptoms include an increase of heart rate greater than 30 beats per minute within 10 minutes of standing up for adults, and an absence of orthostatic hypotension. The symptoms of POTS are caused by an overactivation of the sympathetic nervous system, or sympathetic activity. The most common symptoms can be seen on this slide. Let's look at the pathway that causes this increased sympathetic activation. This slide shows the normal physiology of a patient without POTS. When you stand, there is a decrease in central blood volume from the descent of blood and the shift of plasma volume from blood to interstitial tissues. This leads to a decrease in blood returned to the heart and a subsequent decrease in the amount of blood being pumped forward by the heart. We have receptors in our arteries that can sense this decrease in blood volume that then activate a sympathetic response, which allows us to compensate by increasing our heart rate, increasing the strength of each contraction of the heart, and constricting the peripheral blood vessels to increase blood pressure. For patients without POTS, this physiology ensures that there will be no underperfusion when someone stands up quickly. However, in a patient with POTS, there is an excess of this sympathetic activation. This produces an excessive increase in heart rate, heart contractility, and vasoconstriction, and this excessive response is what ends up producing symptoms. The mechanism behind this phenomenon is still unclear, but there have been some associations for patients with severe POTS, the two most common being an altered venous capacitance, or ability of the veins to increase the volume of blood it holds without a large increase in blood pressure, and the second being a smaller left ventricular volume. These associations make sense because both cause a decreased ability to compensate for a decrease or loss of central blood volume when standing, so therefore a larger sympathetic response is necessary. This slide shows the results of a tilt test comparing persons with POTS to people without POTS. On the left graph, you can see the increased heart rate in patients with POTS after different times and degrees of tilt test to simulate standing versus men and women without POTS. The right graph shows the same pattern, but with decreased stroke volume, or the amount of blood the heart pumps with one contraction. This makes sense because heart rate and stroke volume have inverse relationships. When the heart beats faster, it has less time to reload with blood, so the stroke volume forward with each pump will be less as heart rate goes up. The next post-COVID condition we will cover is vestibular syndrome and symptoms. A study conducted by Tan et al. Evaluated the variety of vestibular symptoms that can arise from patients with COVID. In this study, there were 26 patients with COVID that were criteria matched with 27 control participants. This slide illustrates the inclusion and exclusion criteria of this study. The study found that patients with COVID had multiple and significant differences from those in the control group in regards to vestibular symptoms. COVID patients had worse results in high-frequency hearing tests. They also demonstrated multiple deficits in other tests that assess vestibular function. These tests and values will be further discussed in Module 2. This study also showed no significant difference in central testing, meaning that the deficits were localized in the peripheral modalities, those being within the inner ear and not in the central nervous system. Dizziness is a very common symptom for patients with post-COVID conditions or long COVID. The pathophysiology of dizziness in these patients can be separated into two categories: non-vestibular and vestibular. For non-vestibular causes, these tend to be characterized by those that do not directly have an inner ear mechanism or pathophysiology. Many patients experience the psychological pandemic effect that can manifest as dizziness. There are also medications for acute COVID that have vestibulotoxic effects. Finally, patients have other post-COVID conditions such as dysautonomia and malaise that can cause dizziness. For vestibular causes, there are direct inner ear mechanisms of pathophysiology. Post-COVID conditions can cause persistent inflammation of the inner ear blood vessels. This inflammation increases the susceptibility of ischemia, or lack of oxygen delivery, to the inner ear structures. Due to this ischemia, patients can be symptomatic and experience symptoms of dizziness and/or hearing loss, depending on what structure becomes damaged. Next, we will review post-exertional malaise, PEM, as a post-COVID condition. Post-exertional malaise is another post-COVID condition with a constellation of symptoms as seen on the right of the slide. The distinguishing factor that makes these symptoms due to post-exertional malaise is that they specifically come after a type of exertion. The most common types of exertion are physical and cognitive, but exertion can fall into a plethora of categories. Post-exertional malaise can present as a worsening of symptoms that the patient may already be experiencing, or completely new symptoms altogether. The timing of onset of symptoms after COVID and recovery time is variable depending on the patient. This makes it vital that healthcare providers are aware of these variabilities in order to diagnose and treat properly. The two most common risk factors associated with post-exertional malaise severity are older age at symptom onset and the female sex. In patients with a normal energy system, there are generally two types of ways to produce energy: aerobic and anaerobic. In the aerobic pathway, oxygen is used to break down carbohydrates and fats to make energy. This pathway is usually used for activities that last longer than 2 minutes, like distance running. In the anaerobic pathway, stored energy sources are used from the breakdown of glucose without the need of oxygen. This pathway is used for high-intensity activities or quick bursts of energy, such as short-distance running. In healthy individuals, a mix of both of these pathways are used to give us energy for exertion. However, in patients with post-exertional malaise, through unclear mechanisms, there is a premature ventilatory anaerobic threshold, meaning that patients have a tendency to use the anaerobic pathway earlier and more often than the aerobic pathway. Without ideal utilization of oxygen, patients with post-exertional malaise will tire out and feel more fatigued after a shorter period of time. Next, we will discuss brain fog as a post-COVID condition. Brain fog is defined as a persistent cognitive impairment in attention, concentration, executive functioning, or information processing. The mechanism is thought to be due to the inflammatory response that initiates in the lungs from acute COVID. This inflammatory response can also affect the brain due to the passive spread of pro-inflammatory cytokines or chemical signals through the bloodstream. Inflammation in the brain damages myelin, important components of the nervous system that allow for fast transmission of nerve signals. Therefore, there will be a slowing of brain signals due to this damage, manifesting as brain fog. Secondarily, this inflammation also damages oligodendrocytes and decreases hippocampal neurogenesis, important components of repair in the nervous system. This is why we see symptoms that linger and persist even after acute COVID infection has resolved.